difficult to convert to general anesthesia. During the cervical plexus block, you do want to avoid vascular puncture that would obscure the surgical field via hematoma or dislodgement of microemboli. General anesthesia versus local anesthesia for carotid surgery trial, or the GALA trial, showed no definitive difference in outcomes, meaning rate of stroke, MI, or mortality at 30 days between the two techniques. The cervical plexus arises from C1 to C4. The superficial cervical block anesthetizes the C2 to C4 nerves and allows the patient to stay awake and comfortable during the CEA. Deep cervical plexus block is not required. The nerves emerge from the platysmus muscle posterior to the sternocleidomastoid. Supply sensation to the jaw and neck, occiput, and areas of the chest and shoulder. And obviously you want to avoid the external jugular vein when performing the block. A deep cervical plexus block does not provide improved comfort compared to superficial block, but has been found in studies to increase complications from block placement and then conversion to a general anesthetic. You want to position the patient supine, head turned away from the side of the block. The sternocleidomastoid muscle is identified. You want to mark the lateral edge. At the upper and middle third juncture, the block needle, usually a 5 cm needle, is inserted in a cephalid direction as shown in the diagram at the bottom toward the mastoid process. 5 milliliters of local anesthetic is injected subcutaneously. Next, you want to pull back on the needle and then advance it in a caudate direction along the posterior border of the sternocleidomastoid muscle, injecting an additional 5 milliliters of local anesthetic subcutaneously. Alpha-2 agonists may be used for sedation during CEA. Dexmedetomidine appears to reduce hypertension and tachycardia, but it can increase hypotension. It also reduces postoperative analgesia requirements in the PACU, usually used at a dose from 0.2 to 0.7 micrograms per kilogram per hour. Clonidine IV at 1 microgram per kilogram per hour suppresses the hyperadrenergic response to carotid endarterectomy surgery. It also increases hemodynamic stability with superficial cervical plexus block, but can also increase the incidence of hypotension postoperatively. Under intraoperative management, the primary goal is going to be maintaining perfusion of the brain and heart. Under hemodynamic monitoring, you want to have a close regulation of arterial blood pressure and avoidance of tachycardia. Number 1, you want to make sure you place an arterial line. It's almost always accomplished to perform an A-line during the surgery. ECG monitoring should include the P5 lead for ischemic detection and continuous ST segment analysis. A central line is not usually required unless the patient is unstable. 2 IVs, at least 1 large bore, should be inserted. Under end-tidal CO2, you want to maintain normal carbia, so you want to beware of any hypercapnia that can contribute, 1, to intracerebral seal, and then hypocapnia that decreases cerebral perfusion. So your goal should be normal carbia. A central venous line, pulmonary catheter, or TE, transesophageal echocardiography, may be necessary with severe coronary artery disease or poor ventricular function, but it's rare. If a central line is placed contralaterally, prevention of a hematoma formation should be maintained in order to diminish compromise of the collateral blood flow during cross-clamping. Now, what you want to have available in the room are your vasopressors, primarily ephedrine and phenylephrine, and your vasodilators, nitroglycerin and nitroprusside. You also want to have atropine and glycopyrrolate. Under cerebral perfusion monitoring, the awake assessment is the gold standard. It's also the simplest, most cost-effective, and most reliable method. Now, your EEG is a sensitive indicator of inadequate cerebral perfusion during carotid endarterectomies, but its use is limited due to 1, EEG may not detect subcortical or small cortical infarcts. Also, you have false negative results that are not uncommon. Patients with previous strokes or TIAs have a high incidence of false negative test results with the EEG. And the EEG can be affected not only by cerebral ischemia, but also by changes in temperature, blood pressure, and depth of anesthesia. SSEPs, or somatosensory evoked potentials, can detect specific changes resulting from decreased regional cerebral blood flow, but it's hard to distinguish if these changes are due to anesthesia, hypothermia, changes in blood pressure, or cerebral ischemia. Now, stump pressures, or back pressure of the internal carotid artery, is a poor indicator of the adequacy of cerebral perfusion. Pressures of less than 50 millimeters of mercury have been traditionally used as an indication to shunt by the surgeon. Transcranial Doppler ultrasonography, or TCD, measures continuous medial-cerebral artery blood flow velocity and the occurrence of microembolic events. It can be used to determine the need for shunt placement or malfunction, and monitoring for postoperative hyperperfusion. Cerebral oximetry allows for non-invasive continuous monitoring of the cerebral oxygen saturation, or RSO2, in the frontal lobe as a marker of cerebral perfusion, but it does have minimal value in this surgery. The surgeon may choose to insert a shunt in all patients, and the shunt can manifest increased emboli. Other than the awake assessment, none of these techniques are sufficiently reliable. During induction of anesthesia, you want to avoid hypo and hypertension. Propofol and etomidate are popular choices for induction because they reduce cerebral metabolic rate proportionately more than the cerebral blood flow. The patient may be hypertensive despite having taken the morning antihypertensive and anti-angiogenic medications. These patients are often most prone to hypertension after the induction of general anesthesia. Number 2, small doses of an opioid or a beta-adrenergic blocker can be used to blunt the hypertensive response to endotracheal intubation. And number 3, you want to avoid histamine-releasing NMDAs that can cause tachycardia. Under airway, you want to make sure you maintain a smooth intubation. You might consider using a LTA, and you also want to secure your ETT to the opposite side. Under fluid management, your maintenance intravenous fluid should consist of glucose-free solutions because of potential adverse effects of hyperglycemia that we mentioned earlier. You want to limit the total fluid administration of 10 milliliters per kilogram in a typical 2-hour operation because fluid overload can contribute to increased postoperative hypertension in this type of surgery. Under maintenance, you can consider volatile anesthetic or TIVA, total intravasous anesthesia. General anesthesia is maintained at lighter levels that permit EEG monitoring and also can maintain blood pressures in the high to normal range. Theoretically, isoflurane may be the volatile anesthetic of choice because it appears to provide the greatest protection against cerebral ischemia. Desflurane and sevoflurane may accelerate awakening for the neurologic exam and may also be a good choice. Number 2, you want to look at propofol. Using propofol and remifentanil for allowing for fast wake-up. These also preserve cerebral autoregulation. Some clinicians will use remifentanil in a continuous infusion of 0.05 to 0.2 mics per kilogram per minute, and light levels of desflurane and sevoflurane because of the beneficial effects on the incidence of cerebral ischemia and rapid awakening. Under normothermia, number 3, you want to make sure you maintain that. Hypothermia has not been shown to be beneficial in CEA surgeries. Number 4, you want to maintain normal glucose levels. Make sure you have your glucose monitor and iStat in the room. You want to maintain a smooth extubation, avoid hemodynamic instability or coughing, and it's very important to verify neurologic integrity before leaving the OR. During carotid cross-clamping, you want to make sure you have your heparin and protamine in the room. 5 minutes prior to clamping, per the surgeon, you're going to administer heparin 50 to 100 units per kilogram. You're going to check an ACT if you have that available. You know your value, what you're looking for is greater than 250 seconds for your ACT. During cross-clamping, you want to keep your blood pressure within the upper 20% of your baseline to increase cerebral perfusion. After shunt placement or shunt is in place or after unclamping, you keep your blood pressure in the lower 20% of baseline, which is why it's important to establish your baseline blood pressure in the beginning. Under reversal for your heparin, per surgery you may reverse with protamine. Usual dose is 1 milligram per 100 units of heparin given. Max is 50 milligrams per 10-minute period. Beware of any allergic reactions. There's a high potential for this, and rapid administration may cause severe hypotension. Under intraoperative complications, hypertension is very common. You must administer an intravenous vasodilator to combat the hypertension. Nitroglycerin is used for mild to moderate hypertension because of its beneficial effects on coronary circulation. If you have marked hypertension, use more potent agents such as nicardipine, nitroprusside, clofidipine. Beta-adrenergic blockade facilitates management of hypertension and prevents reflex tachycardia from vasodilators, but should be used in caution, especially when using your longer-acting agents. If you have hypertension, you're going to treat those with vasopressor. Phenylephrine is considered the vasopressor of choice by many clinicians for this surgery, but you want to make sure you give them small increments to avoid hypertension. Reflex bradycardia heart block can be caused by surgical manipulation of the carotid baroreceptor. You want to treat these with atropine and temporary cessation of the manipulation. You can also consider glycopyrrolate. The surgeon may infiltrate the area of the carotid sinus with lidocaine, but the infiltration itself can produce bradycardia. If you have any signs of cerebral ischemia, this would warrant shunt placement by the surgeon. This shows a reference chart for common vasodilators for the treatment of hypertension. You can look at it at your leisure. Under postoperative complications, the patient should be observed for cardiac area and neurologic complications. Hypertension is frequently seen in the immediate postoperative period, often reaches its max at 2 to 3 hours post-op and persists for 24 hours. Patients with postoperative hypertension have a 3 times the neurologic deficits seen as opposed to patients who don't have hypertension. Treatment is long-acting antihypertensives such as hydralazine and labetalol at 5 milligram increments. You may consider, if it's not controlled, by giving short amounts of hydralazine, labetalol, nitroprusside, nitroglycerin, or clofidipine infusions. You first, though, want to exclude other causes of hypertension such as bladder distension, pain, hypoxemia, and hypercarbia. Mechanisms of this postoperative hypertension may be related to altered activity of the carotid sinus or loss of carotid sinus function resulting from denervation during the surgery. Hypertension is less common than hypertension, but can be caused by carotid sinus hypersensitivity. The carotid sinus that was previously shielded by the plaque is now able to sense blood pressure oscillations more clearly, becomes hyperresponsive. It's usually treated with vasopressors such as phenylephrine, typically resolves in 12 to 24 hours. Post-op hypertension is less common, but like I said, it can be caused by residual effects also of anesthetic drugs, overzealous treatment of hypertension, and baroreceptor resetting after the increase in the flow. If the patient is asymptomatic, it is usually well tolerated. Myocardial infarction or ischemia. Tachycardia and hypertension may precipitate acute myocardial ischemia and failure, and hypertension may lead to cerebral edema and or hemorrhage with increase in hematoma formation. Significant hypertension and hypotension may result from myocardial ischemia and infarction. You want to obtain a 12-lead EKG in the recovery room in hemodynamically unstable patients. Preoperative myocardial ischemia may occur in 15% of CEA patients. Some important risk factors include angina and hypertension. Hyperperfusion syndrome. This results from blood flow to the brain in great excess of its metabolic need. It may present several days post-op. Symptoms are severe ipsilateral headache and progress to developing signs of increased cerebral excitability and seizures. Transcranial Doppler may play a role in the syndrome prediction. Steroids may be used in its treatment, but you also want to get down the blood pressure. Respiratory insufficiency may be caused by recurrent laryngeal nerve or hypoglossal nerve injury, neck hematoma, or carotid body dysfunction. Hematoma is seen in 1 to 2% of patients with CEA. Small hematomas can be caused by venous oozing, can be treated by reversing residual heparin with protamine or applying gentle pressure for a few minutes. Expanding hematomas must be immediately evacuated because tracheal compression and loss of airway may occur rapidly. Hematomas are more common and delayed if a patch angioplasty has been performed. Some clinicians may routinely reverse heparin with protamine in patients who have patch angioplasty. Some studies have suggested that protamine may contribute to postoperative stroke, but in the 1991 North American Symptomatic Carotid Endarterectomy Trial or NASCET trial, heparin reversal using protamine was not associated with increased stroke. But remember, hematoma would be an emergency in this situation. Nerve dysfunction. Most of these nerve injuries are transient. They occur to the hypoglossal, recurrent, or supralaryngeal nerves. You want to examine for difficulty swallowing. You want to protect the airway and prevent aspiration. Transient postoperative hoarseness can occur from recurrent laryngeal nerve damage and ipsilateral deviation of the tongue from hypoglossal nerve damage. Under carotid body denervation, unilateral loss of carotid body function is unlikely to be significant, whereas bilateral loss may prevent or impair ventilatory response to hypoxemia. Supplemental oxygen should be routinely used in the recovery area. If the patient manifests symptoms of a new stroke or you suspect an acute thrombosis at the surgery site, you need to obtain a CT scan, communicate with the surgeon, and obtain a neurologic consult. In the recovery room, routine ICU care is unusual according to Barish. It has been a subject that is somewhat controversial. In one study, the ICU was only necessary with 4 or more of the following risk factors: stroke, CHF, chronic kidney failure, hypertension, dysrhythmia, and MI. Based on the judgment of the provider, intensive care may be more appropriate for high-risk patients. This concludes my presentation. These are my references. Thank you very much.